All right, let's get started. Welcome, everyone, to our Project Red Solutions webinar, Chief Nursing Officers Challenges 2025, with Irving, Stackpole, and David Renfro. And I will let Irving kick it off. Please enter any questions into the Q&A section, and we will try to answer everything during the webinar. If we are not able to, we will follow up at a later time. Without further ado, Irving.
Thanks, Emily. It's a pleasure to be here. Thank you all for being here. And as I look at the participation list, I'm encouraged with both the range and the number of individuals who've joined us today. It always is helpful to adjust comments to meet the audience's needs. And as Emily said, your questions we take very seriously. And if you put your question in chat or in the Q&A section of Zoom, we'll get to them. So let's get started without too much further agenda. And by the way, I'm in the Eastern United States, and I'm from Boston, so I apologize for the accent in advance. Dr. Renfro is on the West Coast, and of course, he's got that great California accent. So please go to the next slide. What we want to talk about today is the role of what Project Red is, what evidence there is that Project Red is worth the effort of implementation. We want to talk about the process of implementation, and very, very importantly, Dr. Renfro, David will talk about his experience implementing Project Red as a chief nursing officer, as an individual involved in the sector. Next, please. So what we want to do is we want to look at each of these issues and discuss together how they're applied in a practical clinical environment. Next slide, please. The history of Project Red is fairly recent. It was built around a study that Dr. Jack, our colleague, conducted with the approval of AHRQ, the American Health Quality Research Institute, to evaluate the actual standards of care associated with transition from a hospital to home or from a hospital to a rehabilitation study. And what the research showed was that there was a tremendous failure. There were tremendous errors in the transition from hospital to home. This transitions of care error rate was extremely high, and the consequence was that readmissions were rampant in the United States. And this information, this research has been validated in other settings as well. Next slide, please. So what the theory behind Dr. Jack's research was that there would be a scientific or evidence-based restructuring of the process of moving an individual from an inpatient care setting to the next step in their care process. And the goal was to create standards of care, reproducible components, behavioral standards, and systems-based standards that would contribute to a reduction in unnecessary or inappropriate hospital readmissions, improved clinical outcomes, improved satisfaction on both ends of the transition, and to improve the efficiency, that is to say, reduce the costs, the fiscal costs associated with these transition errors. Next slide, please. And the evidence of the need was hinged in this particular, at the start, with the costs associated with inappropriate readmissions and waste in the system, which was estimated in, I think, in 2013 dollars to 11.5 billion US dollars. That is to say, if unnecessary or inappropriate readmissions were reduced by just 20%, the savings to the system would be over $10 billion. It's an eye-popping number. And next slide, please. The studies, the research about the effectiveness of the implementation of the RED or re-engineered discharge standards is very impressive. The research showed that by implementing these standards, that they could lower hospital readmissions by 30%. They achieved 24, almost 25% improved adherence to post-discharge treatment protocols, and that they resulted in significantly higher patient satisfaction. Patients were happier with this process. With the RED standards implement, they were happier with the transition process, and staff was happier with it because they felt better about a competent and a more effective transition of care procedure, and it saved them time. It reduced the time necessary to educate and to effectively enable patient and family transition to the next care venue. Next slide, please. One of the benefits to hospital systems, and there are some hospital system executives on the call, one of the benefits is what I call line of sight. So one of the standards, the systems-based standards in Project RED, improve the line of sight of the health system executive across the care continuum. So we talk a lot about care continuum and attempting to improve the interoperability, the effectiveness of care across these care venues, these care settings. And here we have Project RED, which is a fully validated set of standards that accomplish that very, very effectively. It also improves the loyalty of consumers and referring professionals within the system, reduces leakage across the system. And from a marketing point of view, that may not be the ultimate focus, the most important focus of a nursing executive, but it's a critical element in nursing, in systems-based executives' consideration of whether or not a new program or a project is to be implemented. And its evidence and process-based capabilities are improved among the staff. So one of the corollary benefits of all quality improvement processes, or QIPs, is that it improves the competence of the system and the staff. And Project RED has demonstrated its ability to do that. Next slide, please. Here's a graphic just to show the macro steps in the process. And one of the implementation lessons that the team at Project RED Solutions has learned is that it's very important to start with some easy wins, to have some early easy wins in the implementation of the standards, the Project RED standards, and then to go through that process, realize the benefits, and then to scale the process to a larger environment. So for example, I know that there are nursing behavioral executives on the call in the behavioral setting, and these Project RED standards work very well in those environments. One of the processes might be to look at how transitions are not working for a particular category of consumer, a particular clinical domain, schizophrenia or substance abuse disorder. And then to look at how the standards are implemented, learn the process, implement the process, realize the benefits, and then scale it up to another category or to scale it up to an entire unit, or to even scale it up to an entire institution. And that's what we mean by scale. Next slide, please. The components, the elements that we need on site in order to achieve this, and David will go into this in greater detail, but the first is leadership commitment. There needs to be a commitment to implementing the standards at the very beginning. In the absence of that, what we find is that as soon as the first big ego is encountered, or the first big, we've never done it this way before, obstacle is encountered, the process can and sometimes does certainly runs into difficulties and may even be quashed. So we need significant and confident commitment from the C-suite leadership. We need an on-site champion. We need teams, and we need data. We need access to data. We need individuals who manage the data, who will even enthusiastically help us find the data we need in order to target the changes that will have the most result. I was just on a call this morning talking with a data manager, and when we explained to the data manager what we were trying to do and what the benefits would be, she actually got very excited and was much more enthusiastic about helping us than she was at the start of the project. So that's really critical to change. Next, please. The left ventricle, the beating heart of the change process in re-engineered discharge, is the after hospital care plan. The after hospital care plan is the document that coalesces the ongoing orders for the consumer, the individual relationships that the consumer has with his or her transition team, and a calendar of events, a schedule of events that the individual, the consumer, the patient, the client is required to fulfill in order to ensure the best possible outcomes. And here we have a depiction of what the front page of that care plan looks like. This is just one example, but the underlying principle is that it needs to be targeted for the individual and to have very detailed components to the after hospital care plan. Next slide, please. One of the distinctions that we make is the difference between systems-based changes that are necessary for the successful implementation of Project Red, and the behavioral or interpersonal standards of care. So the first principle, and the one I've already talked briefly about, is the written, printed after hospital care plan that the patient understands, that has to be in place for successful transition from one care venue to another setting. Next, please. And you don't have to try to keep track of all of this. The standards of care are outlined on our website, the Project Red Solutions website, which is at the bottom of the slide here, and will be part of the slide deck that you'll all receive as participants. The second piece, and tremendously important, is the medication reconciliation and education for the consumer. Depending on the research that you look at, somewhere between 40 and 70% of unnecessary or inappropriate hospital readmissions are directly due to failure to comply or adhere with adhere to medication treatment regimens. And I alluded to behavioral. This is especially true in the behavioral and mental health settings. Next, please. The follow-up plan for tests and discharges, how many significant proportion of individuals who are discharged from secondary or acute general admitting hospitals have follow-up tests, lab tests, x-rays, et cetera, that need to be performed we discharge the consumer before these things are done. And how do we know that they are done? We need to have specific scheduled plan for these treatments, tests, appointments that the patient can actually get to make. And that's one of the standards. Next, please. We need to make arrangements, not just tell the patient to make arrangements. We need to make the arrangements that the patient can actually keep and do everything we can to ensure that those appointments are kept. Doesn't make any sense to make an appointment for a Friday if the patient doesn't have transportation on Friday to get to a follow-up x-ray or test. Organize the post-discharge services and equipment if the patient is an orthopedic patient and needs a wheelchair, walker, cane, crutch. Don't just say you need this stuff. Make the arrangements and tell the patient and or the family member, expect the bed delivery on Tuesday, or can you stop by and pick this portable equipment up and get coaching on the wheelchair, get coaching on the walker at Thursday at Ben's Pharmacy. Can you do that? This is all tremendously important. Next, please. This is critical wherever there are indeed standards for discharge compliance, that these be reconciled. So if you're Joint Commission accredited, if you're complying with other state or federal standards, it's important that these standards be reconciled and customized for your specific environment. Next, please. The other critical element is that the PCP, the patient's primary care provider, not be left in the dark, but that this individual receive the after hospital care plan and discharge summary within 24 hours, 48 hours at the latest. Next. And that the meaningful telephone reinforcement within 48 hours, that's a phone call, interaction with the patient and or the responsible party within 48 hours. So these are the systems-based standards that are part of the Project Re-engineered Discharge Solution. Next slide, please. There are also interpersonal, educational, or behavioral-based standards. There's a total of 13. So one of the critical pieces is, while the systems-based standards are being implemented, is to ensure that the consumer and the patient and his or her family member understand the instructions that they're being given. There are famous examples of discharge plans being given patients. And when the patient's readmitted, they bring the discharge plan back, only to discover, the case manager or social worker discovers that that's not the language, the primary language that the discharge patient has. So the first is to assess the understanding and arrange alternatives if the patient does not understand. And you'll see here on this slide the mention of teach back. And this is a very well-established behavioral process whereby you provide teaching and then confirm that the individual understood the teaching by asking what the individual just heard, and can the individual repeat what you just provided in terms of education. Determine the need for a language assistant, provide education about the diagnosis. If you don't know you've had congestive heart failure, it's difficult to manage your condition. Involve the family caregiver in the discharge planning process. Next slide, please. And explain what common problems and what to do if the problems occur. It isn't enough to say if your wound becomes inflamed. People don't know what that means, many people. So it's important to either show them or explain to them experientially if the wound becomes tender to the touch or red or starts to leak liquid, and this is what that looks like. It's tremendously important to be as vivid and as graphic as possible in the explanations of what the untoward or complications are, so that individuals know what to do and what to do, when to do it. Next, please. So these are the standards. And as you can see, as you can imagine, the needed collaboration and cooperation to produce the after hospital care plan includes many people. It includes the clinical staff, consultants, primary care providers, social workers, care managers. It includes nutritionists, physical therapists, and other allied health professionals, as well as the family members of the patient. They all contribute to the final document, which can and should be the cornerstone of the transition of care. Next slide, please. The question then comes, well, how do you get this started? And David will talk about this in detail, but it includes all of these elements. All of these gears have to be in place to make it work. There needs to be leadership commitment. There needs to be agreement between and among care management, nursing, allied health professionals. There needs to be on-site team. There needs to be access to data, because this is all going to be worked through based on the data, based on results. Effective communications, what that looks like. David has got lots of experience in that regard. There needs to be cooperation and support from and with the health information technology or technical team, and the physical document, the after hospital care plan, needs to be drafted or sometimes created. The after hospital care plan is really different from a discharge summary. As having been the consumer of in acute care hospital services, I can tell you that discharge summaries generally look like a bunch of discoordinated reports from laboratory, from physical therapy, from surgery, from anesthesiology. That's not what we're talking about here. We're talking about a cogent, coherent, understandable, step-by-step process by which an individual can move safely and securely from the hospital environment to the follow-on environment, whether that's home or a rehabilitation center or wherever. Next slide, please. The team leaders, the individuals who are the champions of this process, their roles need to be clearly described and defined. Next, please. And the team that's implementing this in a continuous quality improvement environment needs to be recruited, empowered, enabled, encouraged, and developed early and effectively in order to implement the re-engineered discharge model. Next, please. And the takeaway points from this can and should be that RED can reduce waste, decrease hospital readmissions. All of these benefits have been demonstrated in several peer-reviewed journals and AHRQ-sponsored research. And now, next slide, please. I believe we're going to learn the practical matters associated with implementing the process from one who's done it several times over. Thank you, Dr. Renfro.
Oh, thank you, Irving. Appreciate the welcome here and appreciate everyone that's on the call today. I get excited every time I get to listen about Project Red again. So nothing's missed for me on this. One thing I do want to say as I go along, I couldn't highlight enough the Project Red Solutions toolkit. That helps get you thinking a little more in depth about your process and how you're going to get there. The other thing I want to say is in the data presented by Irving, it does say, from the research, an average of 20% reduction, and that's about 11.5 billion. And I just want to share with you that at my specific facility, well over 30% reduction in readmissions using this exact process. And it wasn't uncommon with the groups that we worked with to hit that 30%. Now, the other thing I want to say additionally is there's been so much research in this area that when I went to our research department as we were rolling this out, it's like Dr. Jack has done so much research on this. There's no need for anyone else to study this aspect of it. So we did document closely what we were doing, but didn't have to do a research study because it has been studied so well so far. So we can go to the next slide. One thing I do want to share with you is that when I initiated this, I was a chief nurse. I currently an executive nurse, deputy executive nurse. And I had, and like other things, you try things and you don't do so well. And I had a program that didn't kick off like Project Red did, but then went back, right? You get right back on the horse, and I utilized the toolkit, and we were wildly successful. So some of the things in the evidence that Irving talked about, one, about all the studies that had already been done, and then he mentioned about improving patient and family satisfaction scores. And I'm in a public sector, and so government sector, we have, well over 150 facilities in our region, in our network across the country. And my facility has been number one in trust scores numerous quarters. And we've also been number one in overall patient satisfaction in several quarters. And so I'm not saying that Project Red is the only thing that gets you there. Obviously, there's many factors, but I do think it helped us tremendously. And when you start to look at Project Red and the interventions that are provided, you have to ask yourself, other than the data of readmissions, how do I know we're successful? How do I know what I'm doing is a positive? And so I can tell you that Irving mentioned about the post-discharge phone calls, critical. When we first started those, 60% of our patients didn't know their discharge diagnosis. Most of us would say, how is that possible? It's very possible. Right now, we're up to the greater than 95% of our patients understand their discharge diagnosis. And the other question is the after hospital care plan. We knew that was really successful for us when patients started coming and asking for it when they were being admitted, or they'd bring it to their primary care provider. The last time we assessed, over 50% of our patients were bringing their after hospital care plan to their follow-up appointment with their provider. I rarely remember to grab my notes, let alone my after hospital care plan, to my follow-up provider. So those are just testaments to us to how the system works to our benefit. If we can go back one more slide, I just want to hit. Oh, I'm sorry. Oh, there we go. So, in looking at Project Red, and I know that, AONL has said that, the things that we need to do is more attentive to direct care nurses. And the one thing I want to say about that is often we say, we're too busy to have another project on the unit, or we're too busy to orchestrate this. And I just want to say that in my experience as a nurse leader for quite a number of years, um, that nurses need that side job, right? That side thought, not just patient care every single day. They need to be focused on some improvement, just like you and I do. And so having a project on the unit, I implemented a project early in my nurse manager career. I was told not to because we were low staffed. But 86% of the staff on the unit wanted to become a part of that project, and everyone who was a part of that project did not leave the entirety of that 2 years of the project. So I think things like this not only build that in your team, and they want to be committed and stay. So when we talk about retention in recruitment, these are very positive things for you. And then, of course, Project Red specifically requires interdisciplinary collaboration. And the great part of this is that this is a great role for someone to lead that interdisciplinary collaboration. When I did it, is really the first major initiative at our facility that was led by a nurse. That was critical for us. And of course, there's, you can have the ego challenges every now and then, but it really helped put us all on the same level, because that's all we want. We don't want power or that. We want the same level of voice at the table. And then, of course, work-life balance for you and your staff. And I say that because even though we're doing this at work, it is something that gets our mind distracted from the current trials and tribulations of a very hectic med surg floor, ICU, or wherever you might work. So this is there a single solution? I wish I could say, hey, Project Red is going to solve your overtime problems and all that. No, there's no single solution, obviously. But having nurse-led evidence-based solutions to improve care, it does help you. You do save money because you're not doing unnecessary tests. You're not having to have patients readmitted that cost money, or even, we say readmissions, but even revisits the ED, right? If you really inform your patient and their family, you're going to help reduce those things as well. As I mentioned earlier, Project Red has a lot of frontline nurse initiatives, right? Nursing interventions. And so that really helps us on the front line of patient care everywhere, build in that connection with our patients. And what you end up doing, because you're giving thorough care, is getting to know that patient a lot better. And so this not only gives your frontline a role in leadership for them to test, fail, and improve, but it really spreads that knowledge across your unit or your facility. And also to other leaders as a nurse or whomever, but if primarily I say nursing because it's so nurse driven in this initiative, if a nurse is leading this, you will be recognized in your facility as being on the cutting edge of innovation, technology, and patient satisfaction, and reducing readmissions, which really halts the cost. We can go to the next slide. And one thing I want to say, Irving went over parts of the interventions. And so I want to highlight a few of those things. The med reconciliation, initially in our facility, they didn't even want to tackle it because it was just so big and it was a big stressor. And a stressor for me too, getting calls in the middle of the night about patients being readmitted to the ICU for a medication reconciliation problem. And so we did tackle it. I finally called our chief of medicine, said, I can't sleep. Let's go. We got to do something here. So we did work on our medication reconciliation. When we first started, what we just wanted to look at initially is, do the doctor's orders and the discharge summary and the patient's after hospital, are they matching? Well, there were 60% that matched, but there were 40% that we needed to work on. And 40%'s a lot. And we noticed that it was our process. It wasn't people. A physician could be changing the medication orders at 3 p.m., but the patient was discharged at noon. And so was that translating? No, it wasn't translating. So, now because we utilize Project Red and pull that information into our after hospital care plan, the patient is getting exactly what the doctor wants them to take home. And the process is done always before the patient leaves. Another big thing for us was arranging patient appointments. We'd send them home and then contact them for their appointment, tell them when it was. And part of Project Red, we started to make the appointments at the bedside. So you see there are some strong, and for every patient, not just the patients who qualified for Red. So we were hardwiring those interventions. And Irving mentioned about the hospital, letting them know when the hospital bed would arrive or the oxygen. Well, we tackled that through Project Red. Guess what? Our patients get their hospital bed at home before they arrive. Their oxygen, same day delivery. They have it on the way home. So this helps you really parse out all those different parts of a discharge and improves the overall patient satisfaction and the readiness. We don't want them going home for a day or two, sleeping on the couch because they can't get upstairs or whatever. And then the meaningful post-op follow-up calls. We've found tremendous things from our patients from those phone calls because we take the time to listen. Um, yeah, and so then, often the other thing I just want to say is the teach back part. Some nurses will tell you we don't have time for that, it's too time consuming. And I have shared if we're not going to do teach back, we shouldn't teach the patient. There's no understanding, right? The patients, I've followed through on my little tracers or Gembas to find out what the patients know. One night at 9 o'clock, a patient was being discharged late at night, and I went up to him when I was a chief nurse and said, "Hey, when's your follow-up appointment?" And he said, I don't know if I have one. Well, the nurse went over it, but we didn't teach it back. That's a small piece, but a piece that the patient probably would have missed. So um, we can go, oh, so let's see. Sorry about that, got off track there. So we can go ahead and go to patient experience. As I shared with you, we're like #1 across the country in our system, and we continue to be at the very, very high. When we were #5, we wanted to have a high five for #5. By the time we had the party, we were already #4. So, this really catches up with us. Nurses and other care management professionals report higher levels of satisfaction clearly. As I shared with you earlier, we had very little losses during our project. And yeah, we get to go. Let's go back to the slide that says impact. My story. There we go. Impact. One more. So I want to share with you a little bit about us. We started our project in 2010, and my first vision when I started off with Project Red, I knew already that it was something that was, one, so well researched that I knew that this would be positive. I also knew from hearing from Dr. Brian Jack himself, we have to implement all elements, all of those parts that Irving talked to you about. We couldn't just do just the after hospital care plan and just med reconciliation. We had to do the whole list. I knew that was important because I wanted the same results that Dr. Jack had received. And so we did that. But when we did that, we were thinking about spread already. How can what I do here in this unit or this facility, how can I make that so it's easily replicated across the country for our system? I will share with you that we have implemented it or spread it, rather scaled up to over 16 facilities within our system. That's a big change, right, for all these facilities. So we have taken those actions, and that's helped our leadership move things forward and being recognized. Our facility is recognized nationally for our work with Project Red. So that was our first vision, and then we took that and then saw how we could then hardwire all of those elements. And I have to tell you, we reached our greater than 30% reduction in readmissions. But additionally, we started building inquiry in our nursing staff. And what happens when you build inquiry? You get a stronger evidence-based practice in your unit. And if you have shared governance in your area, you'll see where those changes then develop in those areas. When I talk about engagement, many of you, I'm sure, have all employee surveys once a year, or maybe you're doing Pathway to Excellence or something like that. And I want to tell you that the engagement of our nursing staff, when just last year, we had 86% of our staff respond to the all employee survey. And that's a lot. That's a lot of staff. I hear most facilities, 56, 60, 86%. And then doing our Pathway to Excellence survey, the first 3 days, 60% of the staff. The next week, we were up to 82% of the staff. So this tells you how when you start building these little blocks across your healthcare system, and I credit Project Red for so much of our engagement with our staff, that you start building these things that then ripple out beyond. As far as the impact here, our patient experience, as I already said to you, being #1 in trust, I think if there's any metric that I want to judge my leadership off of and my impact on my nursing staff and the veterans, it would be the patient's trust in us, because that means a lot more than they like us and they refer us. It takes a lot to trust the providers in a hospital when you're sick, when you're at the worst you felt in your life. And so that's one thing that we really treasure at our facility. As far as staff experience, we have really good scores from our staff. And what does that result in? That means what? We're listening to them. And that's part of Project Red too, building in those listening skills with your patients. You have to have that same affect for your nurses. And when it comes to Project Red and you're at the table, listening to their suggestions. I know it's hard for us sometimes to think that we don't have all the answers, but honestly, they always come up with better solutions than what we would come up with. My goal is to never, ever take anything off the table. Try it once, see if it works. As crazy as it may sound, see if it works. And then, as far as the leadership and demonstrating quality improvement, continuous improvement, being in this mindset, regardless as you go through Project Red, you're going to be thinking about all of these things constantly, especially in today's environment where we are trying to drive down costs. And so I would say what we do is we track, we trace. All of you with Joint Commission, you do tracers. We track, we trace, and see what's going on out there, visualizing it in person. And then we present. Of course, please brag, those easy wins that Irving was talking about. Brag about your teams, share, publish, and present it. And then the others around you, do your best to pull them up. Next slide. As nurse leaders, we're expected to lead, right? And you know, the IOM more than a decade ago said they shared they didn't want to see if nurses would come to the table. They were demanding that we do come to the table. And so you have to ask yourself, well, what are the three traits of a really strong nurse leader, especially when it comes to innovation and excellence? One, emotional intelligence, and clearly that's being able to see all of your surroundings and know how to move forward. There is not a facility, I'm convinced, in the country where nurses can't lead something major, a major initiative like this. Effective communication. We heard that with Teach Back, but it's also with our staff. If you effectively communicate to your staff, and that means effectively listening, that also is one of the strongest three traits. And then adaptability and flexibility. And you'll see as you roll out Project Red in your facility, that's what it requires. You're not going to be able to do the same exact thing in your facility as I can do in mine, because maybe the culture of that unit, the culture of your providers, or the culture of your social workers, all that you have to take into context. So according to Harvard Business Review and the Center for Creative Leadership, those are really the three traits for us to focus on. There's great literature out there when it comes to this, but I like to say, what are the top three things? I can add things later, but I'm not going to try to do 15 things. Next. So, your story clearly can be better than my story, and I certainly want to hear about that for sure. But, the one thing I do want to share is that the number one trait in leaders that are successful is for the spread of innovation is curiosity. And so you're proving that today just by being on this webinar. And so you've taken the first step in that. But additionally, as a leader, we're really interested in our nurses developing that curiosity and that inquiry. And so I want to share a few things with you that we did in our Project Red rollout that helped us look at building that inquiry in our staff, and what did they come up with. So one of the first things that we're really proud of is, before it was even really a popular thing out there, we were already looking at food insecurity. And we built that into our Project Red program because we started thinking, the nurses in their inquiry, like, our patients are in the hospital for 3 days. How long is meat good in their fridge, right? They have to throw it out after 3 days. What else is in the refrigerator that they can go home to eat? Or are we expecting them to go grocery shopping before they leave? And so how can we create some kind of a guide to help them get food to their house, or help them get food before they leave? And we're in the process of creating our own little food bank with sustainable food for a few days. But to assess that, a pretty high number of our patients were food insecure. And I can guarantee that the majority of your patients, if they don't have a lot of caregivers in their house, they're going to go home and not have a bunch of food. And we don't want them having a cup of noodles or Spam or other canned high sodium foods. we definitely want to try to keep them away from that. So looking at that then sprung off of Project Red. And we built such a reputation as leaders in the facility because of the program and the structured way that the Project Red Solutions Toolkit drove us, and that was so interdisciplinary, and how we broke up our teams, that we became leaders in the healthcare system for many things. The one strongest thing I credit our team for, or what we built with Project Red, was the interdisciplinary team. And our key principle was process, not people. And that really drove us into looking at the process. And physicians in the meeting would say, "Oh, that was my patient." We're not talking about you or your patient. We're talking about the process. And so that was really difficult for us because we weren't in that culture. But driving that culture in to your major initiative is going to last you as a nurse leader through other initiatives you move forward. You're going to want to tap the same people on the shoulder when you get this done and it's so successful. But always remember, it's our job as nurse leaders to tap other people on the shoulders and build them. To maybe not lead the next initiative, but to coach your deputy or the person down one to help lead that next initiative. We always are looking at trying to build that succession planning. And I think Project Red gives us a really good opportunity to look at the whole scale of our healthcare system. And I think that Irving mentioned about having that view of the whole transition. You will become more concerned about the transition to nursing home care units or the transition to a rehab unit. You won't just be focused on doing your discharge. And so, with all that, I say that there's so many things here that will stand you apart as a leader. I personally, with my team, have done national presentations and IHI presentations and have rotated with the same thinking that we mentioned earlier about that succession planning and building more nurse leaders. We have a real opportunity right now as nurse leaders in the healthcare systems to develop our leadership, to demonstrate stronger communication, and to help our healthcare facilities drive innovation and excellence while focusing on the evidence just like Dr. Jack has presented for us right here with Project Red Solutions. I thank you, and we are very open to your questions.
Thanks so much, David. It's really a tremendous explication of the value of Project Red in the healthcare environments. And I have a thought and I have a question for you. I know we have some questions from our audience, but the thought I have is as a metaphor improvement in healthcare, we have always assumed that starting with an element of the healthcare delivery system was better than trying to tackle the whole thing at once. So start small and scale up. And in a very important way, quality improvement processes are built around that assumption that you're going to develop your own evidence, that evidence will then be tested and reapplied, and that further evidence will be developed, and that in that process, as you so eloquently said, you pull along all of the participants, and those participants include today's nursing leaders, as well as tomorrow's nursing leaders. So I see an enormous number of corollary blessings, corollary benefits from undertaking Project Red as a quality improvement initiative in healthcare and in particular in hospitals. So I think my observation is that this is a great metaphor for how this can be done, and you've got the experience to back that up.
Can I just say one quick thing about when you look at Project Red, the scale seems so big. And, when I first looked at Project Red, I was like, well, there's only, 12 little standards here. And it was kind of huge. But this, again, just tagging into what you're saying, gave us such an opportunity to build 12 teams, 12 teams that worked and came up to us. So not only did we assign everyone to a standard, we assigned them a team to work with at our facility. So it was broad, but I also knew from Dr. Jack's literature that I couldn't skip any part of that if I wanted that 30%. And that was critical for us in our thinking.
Right.
So yes, it does seem big. And I agree, most quality improvement plan, do, check, act in a little area and see if you spread. And I think that that's doable to take just a surgical area or whatever. But the whole time that you're doing that, you are thinking about how am I hardwiring this practice to impact more. And so I can just share with you briefly the things that we hardwired that are for every single patient, the after hospital care plan. They might not get the full Project Red, but they are going to get that after hospital care plan. They're going to get their appointment before they leave, and they're going to get their discharge equipment timely. So there's certain things about Project Red that you hardwire that every patient gets, no matter what. That's just the way you do business, and then you've got those patients that you can really focus on. So yeah, it seems big, but when you have 12 mini teams, it's doable.
Yes, and I think what we're trying to say to our audience is that it's doable, and the proof is you've done it.
Yeah.
And that's what's exciting. I had a very simple practical question, and then we'll get to the other questions that are coming in. In the post-discharge telephone follow-up, which most, they're required now.
Mhm.
Do you use a script, or do you use how does the individual who's making that call structure the conversation?
Sure. We do a script, but I think the most critical part of that is we use teach back in that call. And so there are many times patients don't understand something, and they want clarification of something, or maybe a dose of their medication was changed. They were educated on it, but now they're home. They're not sure if they want to try that new one because they still got some of the old one left. Should they finish that? Those types of things. So yes, it is scripted. And we do from time to time add in things that we're wanting to assess in our Project Red discharge process. And that could be just timeliness of their stuff getting home. Did that work out for them or whatever? But we do add things to that. It is scripted. It's done by a nurse who loves the role, which is really important. And we reach 98% of all of our discharge patients. 98% we make contact with. And so before, and I know there's a rule out there somewhere, it's like you try twice, or on the third time they don't answer, you don't have to follow up. That's the rule, but we follow up till we make contact.
That's terrific. Well, thank you, David. And Emily, what questions do we have?
All right, first one. Thank you very much. What specific measures can nurse leaders take now, as you start thinking about, potentially implementing Project Red?
I'll take that.
Yeah.
I think a great one right now, as you're thinking about Project Red, is to set up a system where you hear from your frontline nurses every day, from your charge nurses, and just start getting a tally of how many readmissions they got. What you inspect, they respect. So you'll find out from every unit or from the ED how many patients were readmitted. That's going to give you a strong baseline to work on. Start taking note of readmissions that come in that go to your ICU. I think that was the most powerful piece of data that I had to share was, hey, we had X number that were readmitted for medication reconciliation to the ICUs. So I say that's a really good fire starter for you because you need that platform when you meet with your executive leadership. They may not see this as your biggest problem, but clearly one readmission is one too many.
Thank you. I would just say also taking a look at the Project Red solutions in the toolkit is available on the website, and we'll provide that link as well for
Thanks, Emily.
yes, thank you. Okay, how do you see Project Red evolving over the next few years?
Wow, what a good question. So I'll start with that one. My hope is that the economical and efficiency and staffing satisfaction that results from implementing a re-engineered discharge, my hope is that those benefits will be sufficiently compelling that more and more hospitals will begin to implement this. The other factor that we know is happening is that the post-acute care environment is under more and more pressure from staffing and economic reasons. So hospitals can't just are having difficulty with the historically routine discharge transition process. So hospitals need a better, more efficient, more effective way to insulate themselves from staff dissatisfaction and inefficiencies. And my sincere hope is that Project Red, if it isn't just Project Red, but transitions of care processes will increase in penetration from a current rate of about 30% to 40, 50, 70%, and that the economics and the human-based benefits will be even more manifest. I hope that answers the question.
Hey, I would like to just add something to that, and that is, as you do Project Red and you find more about your culture and your facility and your processes, you may find things to add that are gaps in your readmission process that maybe haven't been identified elsewhere. And then if you move forward and share and publish, then that's a way that Project Red then also adapts all those new findings. And it's beneficial for everyone, beneficial for you, and also beneficial for those of us who are on the red journey for eternity.
For eternity. All right, we just have a couple of minutes left. Given the ongoing staffing shortages in healthcare, how can Project Red help nursing leaders address these challenges?
David.
Well, I think that is a great question. First of all, I can help you address the challenges by not losing what you have. And also, nurses, when they're going around looking at facilities to join, we know that magnet and pathway are things that they look at as pluses, but also project-based dedication to project-based nursing projects. And so they're going to want to know that when they come to your facility, and you're going to be bragging about it for sure, that there's room for them to grow. And not just as a bedside leader with IVs and blood draws and all that, it's grow as a leader. And so that does this for every single nurse. They get involved in these things and it helps them. Even when one of our nurses had to meet with a doctor, we went with her, but let her do the talking. So if you have that environment of leadership, that's going to be very attractive for them to help bring them on board.
Wonderful. Thank you so much. Just wanted to, we're at our time. So I just wanted to let everyone know that we will be following up and sending out the slides. So please let us know if you have any questions. And Irving, did you want to close?
Lawyer goes up.
Oh, I think we missed part of that answer. Sorry. You
Yeah,
were
my internet
frozen.
isn't as
Yes.
that the quality improvement programs such as Project Red improves a sense of engagement and
Yes,
loyalty among employees. And this is absolutely the case in healthcare and with Project Red.
absolutely.
Wonderful. Thank you. Well, thank you everyone for attending. We will send out the slides in a follow-up email, and please feel free to reach out to us in the meantime if you have any questions or comments.
Thank
Thank
you,
you,
Emily.
Emily.
Thank you,
Thank
Dr.
you.
Renfro.
Thank you.
Thank you.